Hello, I'm Dr. Cecilia Linde from Karolinska Institute in Stockholm, Sweden, and I would like to welcome you to this discussion on cardiac resynchronization therapy, an update for 2012. I'm joined by Dr. Pierre Bordachar from Hôpital du Haut-l'Évêque in Pessac, France. It's been an exciting 2011. The things that we know and the most important things is the impact of the RAFT trial, which was actually published late 2010. But unlike MADE-IT CRT, the RAFT trial really could demonstrate that in patients with mild heart failure, those in functional class 2, there was a reduction in mortality by CRT, and that was the firm evidence that we needed to establish the true benefit of CRT in this group of patients. This has had an enormous impact on the scientific knowledge and hopefully also on the implantation pattern. But there has been more things emerging in 2011. I'm thinking about how to enhance the response to CRT, namely one of the important things is left ventricular lead position. Pierre, could you expand a bit on that, please?
Yes, to improve the response after CRT, there has been three different approaches. Before implantation, try to find the optimal patient, the optimal substrate. Then during implantation, try to optimize the pacing sites. And after the implantation, try to optimize the programming. The results have been quite disappointing, I would say, for the programming. But as you said, there has been some results about the interest of the optimization of the pacing sites. One of the sub-study of the MADE-IT CRT clearly demonstrated that, and it was quite a surprise, but now it's a trend in different studies, and that demonstrated that the position of the leads, whenever it was anterior, posterior, or lateral, there was not so many differences in terms of prognosis. The only thing that could be demonstrated was the detrimental impact of an apical leads. And clearly the patient with an apical LV lead had more detrimental follow-up and more adverse events than patient with more basal leads.
Yeah, so basically the message there was not to be so sorry if you couldn't reach the left ventricular lateral, posterolateral position, just as long as you avoided the apical lead position, which had an adverse impact. But there's been some other evidence that has been presented but not yet published from the reverse data that actually show the same thing. However, they do show that there is an additional benefit of what we perceived as the ideal left ventricular lead position, the lateral or posterolateral. And it's going to be interesting to read that publication when it emerges.
Yes, these results were quite surprising since in the animal, for example, the apical position seems to be optimal in the dog. In patients, maybe the patients are different than the dogs, but clearly the results are different. And clearly now we see that it's different on ongoing and finished study that the apical position seems to be detrimental. So it seems to be, we need to avoid this position as much as we can.
Yeah, and another thing that has emerged too during the last year is the importance of avoiding scar tissue. There has been the target study, for example, that showed that avoidance of scar tissue has an incremental benefit.
Yes, that seems logical. Now it's a little difficult during the implantation to have an idea where is exactly located the scar. So, but it seems really logical to try to avoid a scar region because probably you're going to be in very slow activation area. So maybe you will have a long activation time once you will pace. So the results are really in favor of trying to avoiding, but in the implantation room sometimes it's difficult to know exactly. So we need the tools to say, okay, to more precisely define where are the area of scars during the implantation.
I believe so too, and then I think we can just firmly establish that left ventricular lead position is a key to successful CRT. Another important thing that has emerged this year is the importance of bundle branch morphology. The sub-studies of MADE-IT CRT clearly show that the left bundle branch patients are the ones that profit. And that same thing has emerged from the reverse trial. and they profit in terms of extent of clinical benefit, extent of reverse remodeling, and also extent of less ventricular tachyarrhythmias. What do you believe will be the impact of this?
Yeah, today we have to follow the recommendation. The recommendations are only based on the QRS duration, but it seems that with these new results clearly demonstrating that, for example, patient with right bundle branch block may less benefit than the patient with left bundle branch block, and maybe patient with right will not benefit at all with the resynchronization in some cases. Maybe in the future there is going to be an adaptation of the recommendation. Maybe in the future once the type of delay, the kind of is this a right or a left bundle branch block will be integrated, maybe integrated in the next recommendation, and then it will have an impact in the selection.
Yeah, it's going to be exciting to see the next version of the guidelines that are due in Europe just this year. What about extent of reverse remodeling per se? That has also been shown to be linked to magnitude of benefit.
Yes, that's also a big problem in the resynchronization. The relation between hemodynamic results and clinical, between remodeling and clinical, it will be much simpler if we could have this kind of relation. These results were promising because at the end there was a relation, direct relation between clinical and remodeling. So if we wanted to optimize the response, it's even more difficult. If we change the definition of response, we will have different responders. I don't know if it's very clear, but if there is a link between clinical and remodeling, I think it's going to be a good thing and try to optimize it.
Yeah, I think we stand here now, we know that broad QRS is important, probably a left bundle branch is important if not mandatory. Female gender seems to derive greater benefit, dilated cardiomyopathy patients derive greater benefit, but we need probably a much larger patient material to discern how to, before implantation, really make sure that we implant this rather expensive but very efficient device in those that are likely to respond.
Yes. One of the things also that have been demonstrated is also the rate of complication associated with these procedures. There has been a European registry demonstrating around 10% of complications associated with CRT. In the RAF study also there was clearly an interest and an advantage of positioning these 3Ds, but associated also with a quite high percentage of complication.
Yeah. So that's a further reason for implanting the device in the right patients. Well, if we look a little bit ahead, there are the new indications are of course the focus and attention, and there is ongoing planning of a multi-center trial that focus on patients with preserved or nearly preserved left ventricular ejection fraction in the region of 35 to 50%. See if those patients will benefit from CRT too. What do you believe about those with very normal ejection fraction, about 50%? Are they going to be the next target population possibly too?
That's difficult. At the beginning, we were targeting patients without indication for pacing, without bradycardia. I think that really the first step is to see what happens in patients with less sick patients with more preserved ejection fraction. We know that right ventricular pacing can be detrimental, even in patients with quite preserved ejection fraction. There is the PACE study, the 2 years results after the PACE study. We can discuss about the limitation of the studies, but clearly demonstrated that right ventricular pacing was detrimental in terms of remodeling, and that we could prevent this detrimental remodeling with biventricular pacing. So that is promising, but we need more studies and probably with more patients. And
yes. And we do have studies that focus particularly on pacing indications and the importance of CRT versus conventional pacing, the BiPACE trial, but that will not be ready this year. Finally, a few remarks perhaps about if we can have additive value of CRT by adding sensors. There was a big disappointment in the impedance measurement per se this year. In the .HF trial, where there was more hospitalizations by the use of only impedance and nothing else. as opposed to control. But there are other promising data, like the Champion trial, that showed reductions of heart failure hospitalizations by the use of pulmonary systolic pressures for therapy guidance. And there's also been some promising results, left atrial pressures in the homeostasis trial. What do you believe for the future that we can expect, Pierre?
Yes, for sure we need to take advantage of the fact that these patients are implanted. There are possibilities of remote monitoring. So if we can associate some sensors, what is going to be difficult is to define which kind of sensors. Maybe an association between different sensors, between different information, to try to improve the follow-up of this patient. The DOT-HF was disappointing, was even negative, and probably that we need to associate different sensors, and maybe we will optimize the follow-up of this patient and try to decrease the number of hospitalization.
So to wrap up, I think it's been a great year, and we know firmly that CRT is beneficial in mild heart failure. We know rather much about which patient groups are likely to respond more than others, and perhaps the left bundle branch data is the one that's going to have the most impact in the near future. We know more about the importance of left ventricular lead position and perhaps to avoid scar tissue. We know which studies are in the pipeline, and those are the ones with nearly preserved or preserved left ventricular ejection fraction, and the additional use of sensors to enhance the response of CRT and avoid heart-related hospitalizations. So we have a great year ahead of us. Thank you.